very much. My brief is to talk about the indications of vitreoretinal surgery for retinal vascular diseases. My financial disclosure is listed. Traditionally, there's been the classic indications have been vitreous hemorrhage due to any ischemic vascular retinopathy, most commonly diabetes, retinal vein occlusion, EELs. Tractional retinal detachments for various causes, as again, most commonly diabetic retinopathy. Epiretinal membranes associated with vascular retinopathies are not uncommon, as you all know, and same with vitreomacular traction. Now, the more recent indications have been radial optic neurotomy, and by recent I mean within the last 10 years or so, and there's been no definitive evidence one way or the other. There have been certainly case series which suggest that it may be of benefit, but there's no definitive evidence, and in this day of anti-VEGF, I think there'd be very few that would be game to do radial optic neurotomy for CRVOs at the moment. Chorioretinal shunting, surgical for CRVOs. As you know, Professor McAllister has shown some good evidence for laser chorioretinal shunting. And people have looked at this in a similar way for surgical chorioretinal shunting. And this, as again, in the days of anti-VEGF, with what we have available, it would be uncommon that we would do a surgical chorioretinal shunt. But I think laser-assisted chorioretinal shunt may be of more benefit in more resistant cases. There's the arteriovenous sheathotomy in BRVOs. This again, I think, would be more restricted to looking at resistant recalcitrant cases, because most people do very well with either anti-VEGFs plus or minus laser for branch retinal vein occlusions. Looking at the evidence for the chorioretinal shunts and the arteriovenous sheathotomies, there's no significant clinical evidence for it. Vitrectomy to improve oxygenation in retinal vascular disease. It's been around for some time. The theory we already know. Again, there's no definitive evidence, and most people these days would reserve this for resistant recalcitrant cases where they've tried most other things first. Same as ILM peeling for macular edema secondary retinal vascular disease. We all know that either people who have macular edema, which we treat with anti-VEGFs, and it doesn't go away, then you could possibly consider ILM peeling, but again, there is no definitive evidence for this. Now, the recent indications have to be taken into account with adjunctive pharmacotherapy. In reality, most of these recent indications have been dealt with by most of us with either anti-VEGF or steroids in some way or another. The surgical indications are more, as I mentioned earlier, for cases resistant to conventional medical therapy or laser therapy, and it's case selection. That's the key to deciding if you want to intervene surgically in vascular retinopathies for either ILM peeling or for macular edema. I think the key is early surgical intervention if you are looking at things like vitreous hemorrhage. Most people in the past with vitreous hemorrhage secondary vascular retinopathies, if you took diabetes as the stock standard one, where the classical indication is wait 3 months, I think most people would agree that they do not wait 3 months any longer. So if you have VMT, ERM, vitreous hemorrhage, most people would err on the side of intervening earlier than we perhaps did 5 to 10 years ago. My brief was only for a short time to look at the indications before the various other speakers. Thank you for your time, attention, and the opportunity to present.